Next, let me call upon Dr. Alok. He will be talking to us on retinal findings in systemic infections. Alok is heading retina at SNC Chitrakoot.
Good morning to you all, and thank you, Dr. Gopal, for this opportunity. So I'll be speaking on some of the retinal findings in systemic infections. The list is exhaustive, so I have restricted myself to 7 cases and since the theme of this IC was Sherlock Holmes, I thought that it would be interesting to present some of the cases. So there is no financial disclosure, although I would like to acknowledge Professor Amod Gupta, without whom I would not have been standing here today. So this is the first case, a 47-year-old male, diabetic on insulin, who presented with sudden diminution of vision in the left eye. And he had history of fever 7 days back, and which was diagnosed as typhoid. So it was a straightforward case for us. We thought that this is endogenous endophthalmitis. We went ahead and did vitreous biopsy, which turned out to be positive for Salmonella typhi. We treated and we got a good outcome, although the vision didn't improve much because of the macular involvement. But this case, again a diabetic, who presented to us with a similar kind of picture, vitritis, with a kind of chorioretinitis, which you can see, focal chorioretinitis. He had foot ulcer, for which he was receiving treatment with higher antibiotics. And to add to the confusion, his VDRL and TPHA both came positive. He was HIV negative, he had anterior segment, and you can see severe vitreous involvement. So what we thought, what we are dealing with, is it endogenous endophthalmitis, is it syphilis, is it toxoplasmosis, because that can also present like this. But what gave us the clue was this OCT picture, which I think Dr. Rima had already shown in one of her case, the rain cloud sign. And this is typically seen in Candida endophthalmitis. So we did pars plana vitrectomy, and we also found yeast-like fungus, and we made a diagnosis of fungal endogenous endophthalmitis in this case. Of course, we had to treat this patient with for syphilis as well. So endogenous endophthalmitis can have various presentation. Mostly they present in patients who are immunocompromised. But in our setup, IV fluids, contaminated IV fluids are an important risk factor for this. Of course, you will have to have a very high index of suspicion to make a diagnosis, and PPV is probably both diagnostic and therapeutic in these cases. Now, this is one of our case, 31-year-old male who presented with history of fever for 5 days and presented with this kind of creamy white necrotizing retinitis without much of inflammation, neither anterior segment nor posterior segment inflammation. And the other eye also showed placoid lesions in predominantly in the posterior pulp, but also few in the periphery. Now, as we were thinking of the diagnosis about 10 years back, Professor Amod Gupta was in Chitrakoot, and we showed similar kind of case to him as a case of which we were unable to figure out, and he had shown that this case was of SSPE. So having that in mind, we decided to go ahead and do an OCT, and the OCT typical, which was very typical of full thickness necrotizing retinitis with sparing of the ILM ballooning, and the sparing of the choroid. And if you can see these 2 pictures, this was just within a day's time that the retinitis has progressed. It was a rapidly progressing retinitis. So we went ahead and did CSF analysis, and it turned out to be a measles retinopathy, or SSPE. Unfortunately, again, this patient died after a few months. Now, so SSPE is the diagnosis is basically based on Daikin's criteria. Unfortunately, there is no ocular criteria for diagnosis of SSPE. Usually, the ocular involvement is seen in 50% of these cases, and some of the cases, the eye may be involved before the neurological symptoms come, and there is usually a rapidly progressive retinitis without much inflammation in the eye. And the OCT is very classic, and as shown by Dr. Neha as well. Now, this patient who came to us from Bhopal, and he was under treatment for post-fever retinitis with azithromycin and steroid. And when we examined this patient, he had this rash in the palms as well as this ground glass retinitis with some pink punctate retinal involvement retinitis. And this gave us a clue that we might be dealing with syphilis, and we questioned him further, and he gave history of genital ulcers, and he turned out to be positive for syphilis as well as HIV. We treated the patient accordingly, and this is the response that we got. Another patient who had this placoid lesion in the posterior pole, which is very typical of syphilitic chorioretinitis, and what you can also see on the OCT is those nodular dots that you see. And if you see this, there are only few differential diagnoses, and one of this is syphilis. This patient we treated with IV ceftriaxone for 14 days, and you can see the outcome. So ocular syphilis can have a myriad of manifestations. However, if you see these two type of presentation, you are by and large sure that you are dealing with syphilitic uveitis. Now, this patient who was a 70-year-old and presented with us with a neck swelling, a mild pain in the eye, and you can see some congestion. And on examination, what we also found, which you can see on the picture, was a mass in the ciliary body region, which can also be seen on the UBM. And there was evidence of peripheral vasculitis. Now, this patient, we did a routine investigation for uveitis. The MAN2 was negative, but when we did HRCT, what we found was a presence of miliary tuberculosis, and when we did FNAC from the thyroid mass, we could demonstrate acid fast bacilli. We treated this patient on ATT, and this was the response. Another case, a 37-year-old male who presented with blurring of vision in both the eyes, and you can see multiple choroidal lesions along with disc swelling, and there was infiltration of the disc as well. Now, this patient, if you see the OCT, which showed a full thickness granulomas, lobulated granulomas, and you can also see at one place there is some amount of subretinal fluid and what is known as contact sign as well, outer retinal involvement. Again, MAN2 was negative, but the HRCT showed presence of miliary tuberculosis. So we treated this patient with ATT and steroid, and this is the response. So TB uveitis, and we have an expert over here, Dr. Rima, can have varied presentation. The diagnosis is usually presumptive and used on the basis of typical phenotypic presentation and positive immunological test. In majority, we don't have any evidence of systemic tuberculosis. However, patients with miliary tuberculosis can also present with ocular involvement, and in most of these cases, the MAN2 is negative, and HRCT can be very valuable in these cases. So despite of a formidable blood retinal barrier, a variety of pathogens can invade the eye, and ocular manifestation can be the first evidence of systemic infections in these cases, and hence you need to have a very high index of suspicion, take a good history, do a very thorough clinical examination, and do targeted labs to make a diagnosis. Thank you very much.
Thank you very much, Alok. So systemic infections are often, you can please stay here. We'll just have a small discussion before we move into, change gears and move into neonates and infants. So we'll just have we have half an hour more. So we'll have a quick discussion on some of the topics that we had. So systemic infections by far is very, very important because it's always life-saving immediately. There is immediate life-saving. So tuberculosis is one common thing which is coming. So a lot of findings, tuberculosis and syphilis can mimic almost everything. So you showed that MAN2 is not a sacrosanct or anything like that. If you investigate further, you will probably come to know. So how much do you investigate? Probably Rima can also come in here. So how much would you think that there is vasculitis, there is retinitis, there are features suggestive of tuberculosis, but systemic tuberculosis is not there. How much should we investigate in? Like, should we get a vitreous tap for PCR, how sensitive or specific is it? Or how much should we be doing?
Thank you, sir. That's a very difficult question to answer, but since the diagnosis of ocular tuberculosis is predominantly presumptive, most of these cases will not have any evidence of active systemic tuberculosis. So we rely on the typical phenotypic presentations that have been beautifully described by Professor Rima and Professor Amod, way back in 2007. So if you have those typical features along with some support corroborative evidence of TB, like a positive MAN2 or a radiological evidence on HRCT of lymphadenopathy, then we tend to treat them as ocular tuberculosis. In PCR usually is, we don't do it routinely in most of the cases unless until it's an atypical presentation. I don't have much experience on PCR. Maybe Dr. Rima can add on it because they have done a lot of work on this. But mostly our diagnosis is presumptive based on the typical phenotypic presentation along with some corroborative evidence of TB. For patients who have systemic TB, it is much easier because then you have an evidence of systemic disease, as I have shown in a couple of cases. Those cases are much easier to diagnose than the ones where you don't have any evidence of TB. But certain phenotypic presentations which are very typical of TB may be very helpful in different.
Rima, you.
I think Alok covered most of the things. So if you go by the COTS publications, to add on to what we have published earlier, some of the clinical signs are very, very, typical of TB unless proven otherwise. So if you have a serpiginous-like choroiditis, systemically the patient is absolutely normal. One immunological test is positive is enough. CT chest, if positive, fine, even if it is negative. If it is serpiginous-like choroiditis, you have from the endemic country, go and treat with ATT. That is the COTS recommendation. For clinical phenotype of retinal vasculitis, any of the immunological test positive, along with a radiological test positive in a non-endemic country, or in an endemic, if you don't have a positive radiological test, go for diagnosis of TB vasculitis. So the main is the clinical phenotype with or without the immunological tests.
Okay. Thank you. So next I would just bring your attention to Mahesh. Mahesh, we spoke about a lot of lifestyle diseases. One of the important lifestyle diseases is obesity. Another one is, sleep apnea. So do you have some thought processes on that?
Yeah, actually, sleep apnea is something we grossly underdiagnose. Nowadays, in chronic CSCR also, we take history and they all, many of them have sleep apnea. So sleep studies are getting more and more importance, especially if the person is having obesity also. So I think sleep studies should be considered. I think it is involved in other diseases like glaucoma also.
Yeah. Generally in sleep apnea also, what happens is because of compensation, hemoglobin increases. And many of these people will have hemoglobin more than 15, 16, and they can go into hyperviscosity syndromes, and they can move into vascular blocks as well. Yeah. Next, cardiological and neurological diseases. Based on OCT, Dr. Neha, can you say whether somebody is, at least if it is an advanced Parkinson's or Alzheimer's, can you say the differences between an Alzheimer's retina versus a Parkinson's retina? A lot of interest have been put onto that.
Yes, absolutely. And as I said, I think we underutilize it as a tool in association with our neurology colleagues. So one of the problems is the age of the patients. This is also the age when there is age-related, deterioration of the RNFL and the ganglion cell complex, the GCIPL, which is said to be quite sensitive. But like I said, in Alzheimer's, there is more of a global loss vis-a-vis even glaucoma or the age-related deterioration. And in Parkinson's, because more of the parvocellular pathway is involved, it is the papillomacular bundle which is affected, and hence more of a temporal loss. But to look at a single OCT and give the diagnosis is not advisable. It's a longitudinal change in conjunction with the rest of the systemic parameters, which is why the AI algorithms might be able to be much better than just a single scan and we give the diagnosis.
So maybe earlier tests to pick up, early parvocellular loss may
Yes.
go a long way in screening these patients.
Screening patients at risk, absolutely.
Yeah. Any other question anybody has in the audience? Please feel free to ask now. Yeah, please. You can go to the mic, sir.
Hello, good morning. Wonderful session. I just wanted to know that when we have made a presumptive diagnosis of a tubercular-related etiology, then what would be the duration of the treatment for the ATT, and how do you decide that what is the right time to stop?
Yeah, you can take it. Okay.
Thank you. And so we usually tend to treat these patients a little longer, about 9 months to 1 year before stopping. Most of these patients, see, in TB, presumptive TB uveitis, the treatment with ATT is basically to prevent recurrences rather than treating the disease. Most of the cases have to be treated with additional steroids as well. So once the disease is quiescent, you can continue with the ATT for about 9 months to 1 year. That is when we stop. But some of these patients, like serpiginous choroiditis, may require long-term immunosuppressants as well. So you may have to continue with the immunosuppressants for about 2 years before thinking of stopping it. Dr. Reema?
Yeah.
Chandran sir. Yeah.
So rightly said. For ocular tuberculosis, the minimum we give is for 9 months, but that's now becoming the maximum also. So I would say 9 months. And we really don't continue the ethambutol for the entire period because the new regime by the pulmonologist is keep giving ethambutol. But you know, we have seen a lot of patients coming back with optic nerve, damage. So we give it for 2 months, the 4 drug, and then wean them off from ethambutol, and the revised regimen is given for 7 months.
And I just wanted to put another question for the expert panel, that suppose we are given ATT and the patient was quiet and asymptomatic for a period of 2 or 3 years, and then there is a recurrence. So how would the treatment be different in the second episode from the first?
So you mean to say the patient has received ATT?
Yeah.
In the first
received
episode?
it for about 8 to 9 months.
So the second episode of
for 2
recurrence.
years he's been asymptomatic. There's no problem.
So recurrences are treated with steroids and immunosuppression. We don't repeat ATT for a recurrence.
Thank you.
Chandran sir.
Yeah, I'd like to know if the retinal, cardiac and cerebral vessels are same histologically.
Chandran sir, we are deeply honored by your presence. And a googly question, very basic in nature. Neha?
Yes, sir. That is what the literature says. They are similar, and the cerebral and cardiac vessels are more similar to the retinal vessels as opposed to the choroidal vessels. And that is why, like I said, in the acute diseases, we might see changes in the choroidal vessels because they don't have the vascular tone. But in the chronic diseases, the changes are seen more in the retinal vessels. So histologically, they might be more similar. Also, I think blood vessels everywhere are similar in terms of the 3 layers, but like we said, because the retinal vessels are so easily visible, they reflect the concomitant changes in the cardiac as well as neurological arterioles and venules. Thank you.
Thank you. Next.